Let's turn to the subgroup of patients with an EGFR mutation, activating EGFR mutation. We have the FLORA trial that showed a significant PFS benefit in the patients who got that first line compared to a first generation EGFR TKI, gefitinib or erlotinib, and more recently publication of better results in terms of CNS activity. Is osimertinib your standard of care first line for these patients, Charu?
Absolutely. I think for several reasons. Tolerability, I think availability, ease of use, and then you can't really argue against the CNS activity as well as the survival, the response rates. I think it's a clear winner on all fronts, and it's been our first choice.
Mm-hmm. Yeah, me too.
Okay. And I think that we have, as a community of thoracic oncologists, have really landed on this as a very strong choice based on that combination of efficacy, very good tolerability, and CNS control, and that now that we can achieve it, we think about it more and more, and it matters more than we had previously factored it in. There are also data that came out on the concept of first-line chemotherapy integrated with gefitinib. This was the NEJ-009 trial out of Japan that looked pretty impressive, in fact, quite impressive, not just for PFS, but even with a 14-month overall survival benefit, and that was using an agent that is really the weakest sibling in that family of EGFR TKIs, but the median overall survival was 52 months. Mm-hmm. I think that was a surprise winner, I mean, along with chemotherapy combined with whatever at ASCO, but does this make a difference? And if so, how are we ever going to incorporate this concept into our treatment paradigm, Haas?
Well, I'm not incorporating it into my treatment paradigm. I think it might be an outlier for all I know at this point. It's one study, and the results are so overwhelmingly positive. You get an occasional study that, despite everything that you think, is either really, really positive or really, really negative, and I think that's why we need confirmatory studies. First of all, it was a different patient population, right? Because it was done in Asia predominantly. There are pharmacodynamic differences. The response to EGFR therapy is a little bit different. And even though, as you said, they used the weaker sibling of all the TKIs in the first generation gefitinib in this study, the way the patients might be responding to these treatments might be a little bit different in Asia than it is in a North America, Northern European patient population. As we just discussed, osimertinib is our standard of care. Am I willing to let go with a single drug with such good tolerability and efficacy in favor of chemo plus TKI? We didn't see any CNS data for chemo plus gefitinib. So there are a lot of things that tell me the study is provocative. I think it's hypothesis generating. But unless I see a study similar to this, with maybe osimertinib in a patient that I see in my clinic, I don't think I'm willing to sort of switch my treatment and go to the chemo plus gefitinib route at this point. And I don't know whether you can argue that you can substitute, either your favorite TKI and just give them the chemo. I think that's a little bit risky. So I like this study. I think it is something we should pay attention to. But in the absence of a confirmatory study, I'm not sure I want to switch my practice.
Although having said that, we know that a fair majority of patients do, either lose their performance status or run out of options, or they're just not good candidates to get second, third line therapy. Mm-hmm. I do like the study design in where you're giving your best, however you may define your best approach first. And I do think that there's some value to that. Again, the study was done with gefitinib and not with osimertinib. So we can't really just plunk in osimertinib for gefitinib in that study and offer carbopem osimertinib to our patients. I don't think we'll be we'll have any shred of evidence to say, yes, this is superior to just using osimertinib. But I do like the concept of coming in with a combination where you can perhaps improve overall survival, not just PFS.
Would you do that in the second-line setting if somebody progresses on OSI? Are you willing to consider chemo plus gefitinib as a second-line option?
I don't think we have data for that.
We have no data on that, yeah.
I would have to say, though, that we as a society and NCCN adopted erlotinib first line in a heartbeat after Japanese-only data with gefitinib. It wasn't even the same TKI, and it definitely wasn't a non-Japanese population. So I think that our readiness to accept Japanese data depends on our biases at the time.
No, I don't think it's that, Jack. It's a different era. We've come a long way since then, baby. We've done a lot of stuff has happened in that time period. We're not as desperate for drugs. We're not as desperate for a treatment option that's reasonable for our patient population. I'm not saying I'm refuting this study because it's not an Asian patient population. I'm just highlighting the fact that there are clear differences.
Stronger competitors.
Absolutely. Okay. I mean, look at the ALK story. Half the dose of the U.S. drug is used in Japan with good clinical efficacy. So clearly there are differences.
That's fair to say that the context is different. And so I just would say, I think that there are potentially differences, but we have generally, and frankly, in J-ALEX versus ALEX, I mean, even if the dose was different, the results were the same. And I'd never felt bad about recommending alectinib in that setting pre that. But I think there's no question we don't have the data yet. I think it is a potential competitor. I think it's most interesting to look at what osimertinib and chemo could do. I think that that could end up being a remarkable benefit, and just that the best opportunity is, again, to ensure that everyone gets the available lines of treatment, and the fact that a quarter of the patients who started on gefitinib alone never got chemo, and this is in Japan where they have a pretty good ability to cross over these patients. So I think that, to me, suggests that hitting it up front may have a particular benefit, but admittedly, we need to study this more. One of the other concepts that came out of Japan, and we have debated how well we should generalize this, is erlotinib with bevacizumab. And a phase 2 trial looked very positive for progression-free survival. That did not pan out for overall survival. And we've seen an additional study out of Japan that looked quite similar. So does erlotinib and bev have any place that you can see, or is that a dead concept?
So I think VEGF inhibition is a valid target in EGFR-mutant lung cancer. I don't know if erlotinib and bev is the way to go in the second-line setting, but I would be very curious to look at the results of osimertinib and bev, which is currently enrolling, and actually interim data were presented that looked quite promising. So I'm not ready to abandon the VEGF inhibition approach. I think it's very valid. It makes sense. It's scientifically sound. I just don't know where I would use erlotinib and bev in the second-line setting.
No, I agree. I think VEGF inhibition is definitely still a valid concept in this patient population. I'll tell you a couple of examples where I have used it. Just adding bev to somebody who might have been on erlotinib in the beginning was, at the time of slight progression, if it was something that I couldn't radiate, or it was, more of a global, here and there, and I really didn't have a lot of options, I have added bevacizumab. I cannot tell you I've had spectacular responses, but I've definitely seen disease stability over a prolonged time. Again, going to the PFS being better, but maybe not necessarily the overall survival. So I have used the agent in that type of a setting. I haven't added it to osimertinib yet. I haven't had that kind of a scenario coming up, so I don't know what that's going to be like. But as you said, I'm hoping that the results of OSI-BEV would give us yet another option for this patient population.